Hola a todos, yo soy Adelina Sanches, yo soy médica nuclear aquí en Brasil y es un placer estar aquí en nombre de Alasvin para participar del curso virtual sobre cáncer de próstata. As you can see, my Spanish is not good, so I'm going to speak in English. I think it will be better for everybody to understand. I don't want to give you this kind of misperception. You deserve more than that. So what we're going to talk today is about the best PSMA criteria to evaluate the systemic treatment of prostate cancer. As an introduction, it's important to understand that prostate cancer is very prevalent, but it doesn't kill as much. Many men will have prostate cancer during their lives, but it's only between the second and the third cause of death all over the world. Most of the prostate cancers are indolent. Eventually, it will be diagnosed in a very late phase of the disease, with the patients already being diagnosed with metastasis, or with even more rare, in a more aggressive form, leading them to develop metastasis during their lives. I'm sure if you already do PSMA PET-CT, we nuclear medicine physicians, I guess, over the last decade, at least for me, it's one of my most pleasures now, is doing PSMA in a routine way. This study has changed so much the way that we see a disease like prostate cancer in such a way that we haven't been doing for many years in a very specific way in one kind of disease. So the prostate-specific membrane antigen, although the name is specific, we see uptake of PSMA, we were learning this over the years, can be shown in other benign and malignant diseases, but most of all, I mean, in an overall daily basis, we see very this method as something very sensitive and specific, changing really the way that we manage prostate cancer, with many changes in the clinical scenario and also in clinical trials. What PSMA is so much better is improving tumor detection in many clinical scenarios. We enhance the visualization of metastatic disease, and lymph nodes and bone and viscera, and this leads to the possibility of personalized treatment guidance. There are many papers showing that when PSMA will describe, we'll see oligometastatic disease, the patient can be treated in a focal way, leading to very good outcomes and making the decision for systemic therapy in a later phase. This is very nice. We are very good detecting recurrent disease in a very early fashion when we compare it to conventional image methods. So we are very good in recurrence, biochemical recurrence. We can reduce radiation exposure, searching for the correct places where the disease is, trying to guide radiotherapy fields. And this is a very resumed way of saying that we're better than conventional imaging, both in sensitivity and specificity. And that's why the use of PSMA PET-CT has been growing so much all over the world, and also industries putting money trying to reach a better molecule with better performance, and people trying to use their own imaging probes. We've been seeing this under development all over the world. The impact on treatment planning starts with correct and good diagnosis. So we are very good diagnosing prostate cancer, staging patients with intermediate to high risk. We localize where the disease is and the amount of the disease we're dealing with, guiding radiation, as I said right before, and also detecting biochemical recurrence. And in all these clinical scenarios, we can understand that correcting, locating the disease will lead to better treatment planning. I'm saying this here again, but showing some images just to illustrate for you. So many papers describing that. And what is the most important for us to think here as nuclear medicine physicians is that we start very well at the beginning of the disease, localizing the disease, knowing the extent of the disease. We can imagine that we're going to do a better treatment for those patients. Maybe with all of that, we're going to get a better outcome. This is the goal of any method, being this method. I'm talking about diagnosis and treatment. And I am sure PSMA will bring that for us nuclear medicine communities. This is not completely proved until now. We're now in August 2024. But a few papers are running trying to show that we can get better outcomes, starting with better diagnosis. And this is the start of what I'll show you. And if we use a very good tool to diagnose the disease, and if I can trust on this tool to evaluate the treatment, maybe we're going to get a better outcome for the patients, right? If we plan to do PET, PSMA as a monitoring tool, it's very important that we need a baseline PET CT. It's not possible to understand a future image without having a baseline. We do this with lymphoma, for example, and so many other types of cancers. It would not be different with PSMA. But I would say that with PSMA, we have to remember that using the same radiopharmaceutical and trying to get the same protocols is also very important, so that you can trust on the tool as a good monitoring tool now to follow the disease, correct? So it's very important. If you change, for example, now we see many radiopharmaceuticals PSMA based. So we have it with gallium-68, with fluorine, DCF pill molecules, and so on. And if you can keep the same radiopharmaceutical, it's better for you to use on your therapeutic monitoring evaluation, okay? Many papers will show this, and I completely agree that if we can use on our internal algorithm as many information as we can, the best, okay? So if we only have the PSMA data to try to say if the patient is responding or not to therapy, we can fail. And I'm going to show you that with some images, and we're going to think about this here together. Of course, the PSMA evaluation needs, and this is very important, that we have strict criteria to say if the patient is responding or not. And this will be based mainly on intensity of uptake and number of lesions. So if the intensity of uptake is growing, you have more lesions, probably the patient is progressing, but not necessarily we're going to see this. If we can put together other parameters like performance status, so if we can do an interview with a patient before the image and know if he thinks, or if the referring physician can tell us if the patient is getting better or not with the current treatment. It doesn't matter what treatment it is. the best for us. If we know the PSA levels, so is the PSA increasing or decreasing is very important. Radiographic data, many criteria will show that we have, for example, most part of the time CT coupled with the PET scans. If we can look at the tomographic data and see if the lesions are changing density, if they're growing, if new lesions are appearing on CT, it's one more data. And also, eventually, even using FDG PET-CT in a patient that we can think that they're losing differentiation, for example, losing the capacity to express PSMA, and, for example, losing performance, and this kind of patient sometimes doesn't even increase PSA anymore, losing differentiation or going into nearing endocrine dead differentiation that doesn't produce PSA, doesn't express PSMA, but usually will be high on FDG expression, I mean, you know, on glucose consumption. So if you put all of this together, the chances that you will misunderstand the result of your analysis will decrease a lot. This is one of the most important slides that I will show you here tonight. Are the papers that I consider most important for you to know and use as the greatest guidelines, criteria to understand what you should use as a PET PSMA criteria to say that the person, to evaluate response of a therapy, right? Okay, so if understand if the patient is progressing or not. Resist and persist are not good for PSMA. I'm sorry. Resist is used for anatomical methods, and persist was described for FDG, and they cannot be translated into PSMA imaging. So we should not use their criteria. It's important for you to understand that. PROMIS is very interesting, and I'm going to share the papers with you, the second version that is more current, was more recently published. And this is the guideline for you to understand how to report and how to understand response criteria on PSMA. And the PROMIS will use these two that I consider are the most strict and easy to use on a day-by-day basis criteria for understanding the evaluation of PSMA to treatment response. So the PPP, PSMA, PET progression criteria is usually used for patients with low-grade disease, low volume of disease, usually patients with still hormone-sensitive disease, and the RACIP, response evaluation criteria on PSMA image. It was developed for patients undergoing radioligand therapy, so they're metastatic, they're castrate resistant, metastatic patients with more advanced disease. Most important of all, before going into this, is this what's written here on the pink below, is that PSMA is not fully available and is fairly expensive method. So if clinically you're working on a patient that is performing very well after a treatment or going back very easily, I mean, PSA rising, losing performance, losing weight, it's very easy to say that the patient is not responding, sometimes even with conventional imaging. So you should not use PSMA PET for those patients. I mean, those who are clearly getting better or getting worse. We should reserve this kind of method, our method, for patients when you have equivocal clinical evidence on what is happening. Sometimes the patient is feeling better, but the PSA is not responding so well. Sometimes the treatment is very expensive and makes sense to use an expensive method trying to give us a better clinical answer if the patient is going well or not, okay? In a very objective way, as I told you, the PPP and RECIP criteria will describe what they consider progressive or not disease based on PSMA results, okay? So the PPP criteria will define as progressive disease if the patient has a volume of disease increasing on at least 30%, and this is very important, will be conjugated with consistent clinical and laboratorial data. So we have a PET PSMA that is increasing 30% or more, and the patient is going bad clinically, and the laboratorial data will also give you criteria that they are worse, okay? If 2 or more new lesions appear or show up on the PET PSMA, you wouldn't need other clinical or laboratorial data. Or if you have only 1 new lesion, but you have clinical and laboratorial data, you can consider this as progressive disease. What would not be progression is all the other patterns that you could find. RECIP, in my opinion, will refine it better, as we are already used to see in RECIST criteria or even PERSIST. It's more similar to what we are used to use in other oncological kind of criteria for imaging, okay? So progressive disease, progressive disease would be total tumor volume increase of at least 20% and showing up new lesions. Partial response if the tumor volume would decrease at least 30% without new lesions. So the appearance of any new lesion is progression, of course, and increase in 20%. Partial response or decrease of at least 30%. Complete response is absence. I mean, it was positive on PSMA before, and it's completely negative after the institution of a new therapy. And stable disease, all other. I mean, any increase or decrease, very slow, of between 20–30%, more or less disease. This is, I mean, it's very important for you to keep this in mind because it will help you in a more objective way. Sometimes on the visual criteria, as you can see here, it can be easy. This is a very clear-cut objective way of seeing that the patient is progressing or not. But sometimes it's not as easy as that. And maybe if we can quantitate the results, but not everyone is going to have this kind of software to calculate the total tumor volume. You should use only visual analysis. But as we can see here on visual analysis, it's the patient, for example, with these lesions here after the treatment. This is interim PET, but notoriously the disease is decreasing. On the total tumor volume, so the computer will calculate how much disease the patient has. It decreased from 63 to 7. So on both criteria, the patient went very well. So this is good response. And this is bad response before the treatment. And then we see a very huge increase of disease that will also translate on the numbers of the calculation of the total tumor volume of 862 to 1,365. So very clear that the patient went good or bad. in clinical practice, I would say that it's not always that easy. Sometimes we see a patient that you are in doubt and the PSA levels go in an opposite way as the PET scan, and we have more difficulty. That's why I told you, if you can use as many criteria as you can, like clinical criteria, PSA levels, tomographic response, or even FDG images, also to get a final conclusion on what is, in which way the patient is going, could help a lot. This is another publication showing now two patients undergoing a scenario that I could not let out of this talk, that is patient undergoing ADT, so new hormonal agents that do a very strong blocking on the testosterone levels. When introduced to the patient, normally leads to very fast and drastic decrease in PSA level. But on the beginning can increase showing up of the receptors of PSMA, leading to false positive progression, described as a flare phenomenon. There are conflicting data on the literature, but most will consider that if we do a later evaluation after the introduction of ADT, instead of in the beginning on the 4 initial weeks, if you put it through at least 3 months at the beginning of ADT, you're going to have less false positive results. Okay, so these are two different examples that were described on this article here. A patient starting ADT with a PSA level of 106. You look at the PSMA PET-CT, we see bone disease here, but slight lymph node disease here. And then you see on the 4th week that many lesions show up, and then you have the doubt, and is the patient progressing, but the PSA level decreased quite a bit to have. And then you repeat the PSMA again, and also, although the PSA level decreased a little bit more, you see that the lesions are still there, and it's very higher. I mean, many more lesions than what you saw on the baseline, and this should be considered as true progression, because you can consider that not all the disease is only responding to PSA. I mean, translated into PSA seric levels, okay? Imaging is very important also. On this patient, however, you see that the PSA dropped from 37 to 2.5, but again, the image seems to be higher uptake and even like a new lesion here. And then you go to the week 12, and then you see that although the number raised a little bit, all the images are more faint than before, and this is considered a flare phenomenon. So if you consider that the patient is going well clinically, you should keep here the ADT treatment, okay? This is very important, very frequent. I mean, nowadays, I would say that like 90% of the patients, both on the hormonal sensitive clinical scenario and castrate resistant, will use ADT. So it's a very common class of drug nowadays used, and then we should be aware of this phenomenon to interpret the PSMA PET-CT in a correct way. Okay. This article will bring again on this table comparing the EAU and EANM criteria for PSMA, and you will see that this is very similar of what I described to you on PPP, on RECIP, and compare it with what is usually considered as progression in bone scan and CT. So it's very important for you to understand that CT will need to show up new lesions, for example, on tomography or magnetic resonance. Bone scan progression would be appearance of at least new 2 lesions on a subsequent scan, if you compare it before treatment. And what you're going to see here on PET, on PSMA PET, is already what I showed you on PPP or a RECIP. So increase of volume of at least 30% to consider progressive disease, appearance of at least 2 new lesions with or without CT change, or both of these, partial response reduction in tumor volume of at least 30%, and complete response disappearance of any lesion when you compare to the baseline, and stable response, anything that is not described on that. Before we go into limitations here, I would say that this scenario of the use of PSMA PET-CT is not nowadays well established as something that we can use with global acceptance, okay? It's not, as we have now, acceptance of staging intermediate and high risk patients and localizing biochemical recurrence. But I think it's a very way to be a new scenario where in a very short period of time we're gonna reach, okay? Still, we have limited availability of PSMA PET-CT, you know that, these are still limitations. Radiation exposure, I would say not so much, because if we have pro-SPECT, pro-PSMA comparing in the scenario of staging PSMA PET-CT with conventional imaging, we demonstrated that we exposed the patients to less radiation. So I think it's not a big deal, a problem. False positive findings, and the most important, I said here, caution with ADT. So when the patient is going ADT, wait at least 12 weeks to make a new PET for comparison. And also, if you have new lesions appearance, make sure that these are within the expected metastatic ways of evaluation of prostate cancer distribution. So if you have a very strange place, do not interpret it as a progression. Be cautious about that, mainly if all the rest is responding. So we have to keep in mind that understanding the whole scenario is very important, as I said before. Interpreting challenges, so sometimes it's not easy. As I said before, sometimes the patient is decreasing PSA, but you show more lesions, or the contrary. So understand the patient stage, previous treatments. It could, for example, the patient could have a fall, and this could be like traumatic trauma, alterations in the skeleton. Reader's experience is very important. So getting those tables with very strict and objective criteria is very important for us nuclear medicine physicians to speak the same language and get the physicians as much as objective data as we can. It's very important. and cost considerations. If we do many PET over the journey of a prostate cancer patient, it can become a problem. But I would say that sometimes having the correct response of what is happening will save money, but we have to prove that we are doing this in a very good manner, as we did in other clinical scenarios. As a future directions, I would leave here, improve PSMA radio tracement development. We've been doing that, trying to reach new molecules with better distribution, cost, and whatsoever. Incorporation of PSMA PET-CT in treatment algorithms. This is, I would say, still in the beginning, but as we make tests and prove the value of the two in many clinical scenarios, we're gonna get very strict ways to use our studies. Multiparametric imaging approaches, so using PSMA, PET-CT together with other modalities such as multiparametric MRI and other imaging studies to get the best to get the best results with imaging methods. And of course, I wouldn't leave this outside of this talk. Artificial intelligence and machine learning can bring us maybe in the future new data trying to give us more accurate parameters and give it more strict to the point to our patients and colleagues. With this, I will finish here, thanking again Alasbin for the invitation, leading you. I understand that maybe you understand in Portuguese, but success doesn't have has anything to do of getting something. Success is when in life, when you feel life inside of you, and this is happening in a wonderful way. So thank you again for the invitation. We'll be together along the course to answer any kind of doubt, and I'll share you all the articles that I mentioned here during the speech. Okay, thanks everybody. Good night.